Okay. Good afternoon. This slide is just to remind myself and all of you that I'm actually the misfit here because I don't do cataract surgeries, but I'll be speaking on combined procedures from the perspective of a person who does only glaucoma. And you think in terms of a combined procedure when you have a cataract and a glaucoma. And there are two basic reasons to operate. One, there's a visual handicap because of the cataract, or the glaucoma is progressing. So that's when you would like to intervene. So there are three options that we have, and I'm just moving away from combined procedures. You could opt for a cataract surgery alone, but in either of these situations where the glaucoma is moderate to advanced or progressing, or the intraocular pressure is not well controlled, that is not what you're actually going to think of. So it would boil down to doing a cataract and a glaucoma surgery together. The other third option is to do a glaucoma surgery first and then follow it up with a cataract surgery. Now, combined surgery or a combined procedure would be one surgical procedure which keeps the health status and the socioeconomic concerns of the patient in mind. When you think about it from a glaucoma perspective, it's the amount of medication that the patient is using, what is the level of intraocular pressure that the patient has been having and what is desired, and what is the assessment of the optic disc. Now, assessment of the optic disc will usually not be possible in a patient with cataract. You can't do structural measurements, but you can always come back and do an automated perimetry, because that will give you a functional assessment of the optic nerve, and you can compare with whatever has been done. Again, to emphasize, patients with a moderate to advanced glaucoma, cataract surgery is not what you're looking at, because the reduction in intraocular pressure is always more when you combine the procedures as compared to a cataract surgery done alone. Even there's a significant reduction in medication if you combine the cataract with the glaucoma surgery and not depend on the cataract surgery alone to lower the intraocular pressure. Now, another reason to do combined surgeries is when there's an advanced disc damage, correlating visual fields. Your primary concern is that when you insert the probe for phacoemulsification, a lot of fluid goes in and comes out, and these small fluctuations in intraocular pressure could further compromise an optic nerve which is damaged. The other reason to think in terms of a combined procedure is when the patient has allergies, the cost of treatment, and a bigger issue for most of our patients is a compliance in a long-term perspective. So again, I said this in the beginning, the two broad reasons: either you operate because the patient has a significant visual discomfort because of the cataract, or the pressure is not well controlled. To put it differently, the glaucoma is not well controlled. So patient may be on a single drug or two drugs, and there's a significant cataract which is producing a visual handicap, and you need to operate. Then the question you're asking yourself is, can I do the glaucoma surgery for him and take him off medication for some time? The other reason is when the pressure is poorly controlled on maximal tolerable treatment and the patient has a cataract and pseudoexfoliation. So we all know pseudoexfoliation is a very important risk factor, and many of us will combine the glaucoma surgery with the cataract. The other reason to do a combined procedure would be when you have a primary angle closure glaucoma, the laser iridotomy has been done, and there is a cataract which is significant enough. So you're asking yourself, if I'm doing a glaucoma surgery for this, can I get out the cataract at the same time? The disadvantages of the combined procedure would be a longer operating time, complex post-op recovery. Remember, the cataract surgery is predictable. The glaucoma surgery and its post-op follow-up is not all that predictable. There's a slower visual recovery because of the glaucoma surgery which has been added. The intraocular pressure control is not as good as it is with a two-step procedure. And then you have bleb issues over a period of time and astigmatism. So this part has already been covered, but I just want to emphasize proper pre-op examination, changes in medication, anesthesia is something you'll have to look at, pupillary dilatation, soft eye, and the confidence of the patient. So coming back to two site at the same sitting, I would prefer a superior nasal glaucoma surgery followed by a clear corneal temporal phaco at the same time. And this is what I had been practicing with my cataract surgeon for many years, and this is just to show you the same patient. Superior nasal trap, the bleb has extended a little more temporally. The clear corneal was done. 6 months later, we did a combined procedure. The other irony is you have a good bleb on the eye which was operated first, and you have a flat bleb here. This patient had now nearly 17 years of follow-up after these two procedures. She's on 3 drugs in the left eye, but controlled at about 11. And she has total cupping in this eye. She had a total cupping in this eye, but this is now 9 without any medication. So just to show you, same procedure, same set of surgeons, the eye response is a little different here. No medication required, and she needs 3 drugs in this eye. It's also been shown that when you compare the two sites with the one side, there's a single study which says 33 eyes followed up for more than 3 months. More medication was required in the eyes which went in for the two-side surgery. But Hampel and all in their analysis, meta-analysis, found that the two-side provided lower intraocular pressure. I think others have actually come back to comment that there is no significant difference as far as it is concerned, and I think that's the larger perspective many of us follow. One side, two side is patient convenience, is the surgeon's convenience, and has no bearing on the intraocular pressure level. There are other randomized controlled trials done, 80 eyes followed up for 24 months. The intraocular pressure control has remained the same. And yes, it's a time-consuming thing. They also found that there was an increase in the endothelial cell count at 3 and 12 months, but at 24 months, there was no difference in the pre-op, post-op endothelial count between the two arms of the study. And they found that IOP lowering was equally effective in both the procedures, one side and two side. The operating time was on the higher side, and there was a higher incidence of post-op IOP in the two-side procedure as compared to the one-side procedure, which actually showed a tendency to a little leak of aqueous, and Siedel's was positive. So again, from a cataract surgeon's point of view, you will have lots of panelists there. From a glaucoma person's point of view, would you do a combined procedure for this, where you can actually see the zonules broken or lax and the lens subluxated? So that's my one question. My other question is here, just to emphasize the same point, you can see the subluxation of the lens here. You can look at this bound down pupil. Would you plan a combined procedure? And this is my fourth choice. Oh, sorry. Patient with an advanced glaucoma, total cupping. Would you actually think in terms of a combined procedure? Thank you.